Anatomy. Soft tissue brain anatomy. Central sulcus. This anatomic landmark separates the frontal lobe from the parietal lobe. Old-school gray-bearded radiologists, likely the ones who are important enough to write test questions, love to ask how you find this important structure. There are about 10 ways to do this, which brings me to the main reason this is a great pimping question. Even if you see name 9 ways to do it, they can still correct you by naming the 10th way. I noticed during my time as a trainee, that attendings tend to be excellent at knowing the answers to the questions they are asking. Practically speaking, this is the strategy I use for finding the central sulcus. Pretty high up on the brain, maybe the 3rd or 4th cut, I find the pars marginalis. This is called the pars bracket sign, because the bihemispheric symmetric pars marginalis form an anteriorly open bracket. The bracket is immediately behind the central sulcus. This is present about 95% of the time. It's actually pretty reliable. Central sulcus. Pars bracket sign. 118. L. Central sulcus trivia. Here are the other less practical ways to do it. Superior frontal sulcus I precentral sulcus sign. The posterior end of the superior frontal sulcus joins the precentral sulcus inverted omega. Sigmoid hook corresponds to the motor hand bifid posterior central sulcus. Posterior CS has a bifid appearance about 85% than post-central gyrus sign. The precentral gyrus is thicker than the post-central gyrus, ratio 1:1.5. Intersection. The interparietal sulcus intersects the post-central sulcus, works almost always, midline sulcus sign. The most prominent sulcus that reaches the midline is the central sulcus, works about 70%. Superior frontal sulcus often intersects the pre-CS. Inverted omega on the central sulcus represents the motor hand. W.A-J. Ultraparietal sulcus intersects the post-CS. Precentral, thick. Post-central, thin. The post-CS is bifid about 85% of the time. 119. Homunculus trivia. L. Central sulcus trivia. Here are the other less practical ways to do it. Superior frontal sulcus I precentral sulcus sign. Superior frontal sulcus often intersects the pre-CS. Superior frontal sulcus often intersects the pre-CS. Inverted omega on the central sulcus represents the motor hand. W.A-J. Ultraparietal sulcus intersects the post-CS. Precentral, thick. Post-central, thin. The post-CS is bifid about 85% of the time. 119. Homunculus trivia. The inverted omega, posteriorly directed knob on the central sulcus I gyrus designates the motor cortex controlling hand function. ACA territory gets legs, MCA territory hits the rest. Normal cerebral cortex. As a point of trivia, the cortex is normally 6 layers thick, and the hippocampus is normally 3 layers thick. I only mention this because the hippocampus can look slightly brighter on flare compared to other cortical areas, and this is the reason why, supposedly. Dilated perivascular spaces, versporobins. These are fluid-filled spaces that accompany perforating vessels. They are a normal variant and very common. They can be enlarged and associated with multiple pathologies, mucopolysaccharidosis, hurlers and hunters, gelatinous pseudocysts, in cryptococcal meningitis, and atrophy with advancing age. They don't contain CSF, but instead have interstitial fluid. The common locations for these are around the lenticulostriate arteries in the lower third of the basal ganglia, in the centrum semiovale, and in the midbrain. Lateral vents ventricular anatomy, just a quick refresher on this. You have two lateral ventricles that communicate with the third ventricle via the interventricular foramen of Monro, which in turn communicates with the fourth ventricle via the cerebral aqueduct. The fluid in the fourth ventricle escapes via the median aperture foramen of Magendie, and the lateral apertures foramen of Luschka. A small amount of fluid will pass downward into the spinal subarachnoid spaces, but most will rise through the tentorial notch and over the surface of the brain, where it is reabsorbed by the arachnoid villi and granulations into the venous sinus system. Blockage at any site will cause a non-communicating hydrocephalus. Blockage of reabsorption at the villi I granulation will also cause a non-communicating hydrocephalus. Median aperture, Magendie. 1-I, lateral aperture, Luschka. Spinal cord. 120. L. Arachnoid granulations. These are regions where the arachnoid projects into the venous system, allowing for CSF to be reabsorbed. They are hypodense on CT, similar to CSF, and usually round or oval. This round shape helps distinguish them from clot in a venous sinus, which is going to be linear. On MR they are typically T2 bright, ISO to CSF, but can be T_bright on flare, although this varies a lot and therefore probably won't be tested. These things can scallop the inner table, probably from CSF pulsation. Cavum variants. Cavum septum pellucidum, seen in 100% of preterm infants, 80% of term infants, and 15% of adults. Rarely, can dilate and cause obstructive hydrocephalus. Cavum virgae, a posterior continuation of the cavum septum pellucidum, never exists without a cavum septum pellucidum, cavum velum ultrapositum, extension of the quadrigeminal plate cistern to foramen of Monro. Seen on sagittal as above the third ventricle and below the fornices. Normal cavum septum pellucidum, cavum virgae, and septum pel/ucidum-. Basal cisterns. The basal cisterns are good for two things: 1, looking for mass effect, and 2, anatomy questions. Some people say the suprasellar cisterns look like a pentagon. The 5 comers of the star lend themselves easily to multiple-choice questions. The top of the star is the interhemispheric fissure, the anterior points are the Sylvian cisterns, and the posterior points are the ambient cisterns. The quadrigeminal plate looks like a smile. Anterior ultrahemispheric fissure + Sylvian cistern. Ambient cistern. Quadrigeminal plate cistern. 121. Brain development. Brain myelination. The baby brain has essentially the opposite signal characteristics as the adult brain. The TL pattern of a baby is similar to the T2 pattern of an adult. The T2 pattern of a baby is similar to the TL pattern of an adult. This appearance is the result of myelination changes. The process of myelination occurs in a predetermined order, and therefore lends itself easily to multiple-choice testing. The basic concept to understand first is that immature myelin has a higher water content relative to mature myelin and therefore is brighter on T2 and darker on TL. During the maturation process, water will decrease, and fat, brain cholesterol, and glycolipids will increase. Therefore, mature white matter will be brighter on TL and darker on T2. Immature myelin, mature myelin. High water, low water, high fat. Relatively TL dark, T2 bright, relatively TL bright, T2 dark. As a point of highly testable trivia, the TL changes precede the T2 changes, adult TL pattern seen around age 1, adult T2 pattern seen around age 2. Should be easy to remember, 1 for TL, 2 for T2. Take-home point, TI is most useful for assessing myelination. Myelination in the first year, especially 0 to 6 months. T2 is most useful for assessing myelination in the second year, especially 6 months to 18 months. Order of progression. Progression, just remember inferior to superior, posterior to anterior, central to peripheral, and sensory fibers prior to motor fibers. The testable trivia is that the subcortical white matter is the last part of the brain to myelinate, with the occipital white matter around 12 months, and the frontal regions finishing around 18 months. The terminal zones of myelination occur in the subcortical frontotemporoparietal regions, finishing around 40 months. Another high-yield piece of testable trivia is that the brainstem and posterior limb of the internal capsule are normally myelinated at birth. Brain myelination pattern. /RIT/ inferior corpus callosum. I'll touch on this again in the developmental/congenital section, but it's high yield enough to repeat. The corpus callosum forms front to back, then rostrum last. Therefore, hypoplasia of the corpus callosum is usually absence of the splenium, with the genu intact. High-yield points regarding brain development: myelination occurs inferior low superior, and posterior to anterior. The corpus callosum forms front to back, with the rostrum last. Both the anterior and posterior pituitary are bright at birth, posterior only bright around 2 months, 2 years. Cavrial bone marrow will be active, TL hypointense, in young kids, and fatty, TL hyperintense. In older kids, the sinuses form in the following order: maxillary, ethmoid, sphenoid, and frontal last. Brain iron increases with age, globus pallidus darkens up. 123. Bony anatomy. Skull base. The most likely multiple-choice questions regarding the skull base are anatomy questions. Specifically, the what goes where question is very easy to write. Foreign contents: I foramen ovale CNV3, an accessory meningeal artery. F. Aramen rotundum. Superior orbital fissure. I. Inferior orbital fissure. F. Aramen spinaceum, jugular foramen. Hypoglossal canal, optic canal. CNV2, R2V2. CN3, CN4, CNVT, CN6. CNV2. Middle meningeal artery, pars nervosa, CN9, pars vascularis, CN10, CN11, CN12, CN2, and ophthalmic artery. The jugular foramen. The jugular foramen has 2 parts which are separated by a bony, jugular spine, pars nervosa, the nervous guy in the front. This contains the glossopharyngeal nerve, CN9, along with its tympanic branch, the Jacobson's nerve, pars vascularis. This is the vascular part, which actually contains the jugular bulb, along with the vagus nerve, CN10, along with its auricular branch, Arnold's nerve, and the spinal accessory nerve, CN11. One. Bony anatomy. R. A. Remember that they don't have to show you the hole in the axial plane. They can be sneaky and show it in the corona or sagittal planes. In fact, showing foramen rotundum in the coronal and sagittal planes is a very common sneaky trick. With regard to the relationship between spinatum and ovale, I like to think of this as the footprint of a woman's high-heeled shoe might make in the snow, with the oval part being ovale, and the pointy heel is spinatum. Imprint of the high-heeled shoe. Foramen spinatum, S, and foramen ovale, O. With regard to rotundum, think about it as being totally level or horizontal on the sagittal view. On the coronal view, it looks like you are staring into a gun barrel. The hypoglossal canal is very posterior and inferior. This makes it unique as a skull-base foramen. 125. The relationship between the superior orbital fissure, SOF, the inferior orbital fissure, IOF, foramen rotundum, FR, and the pterygopalatine fossa, PPF, is an important one that can really lead to some sneaky multiple choice questions, mainly what goes through what. I've attempted to outline this relationship on both sagittal and coronal view. Lead to some sneaky multiple choice questions. Sagittal. Cavernous sinus. The question is going to be, what's in it probably asked as what is not in it. CN3, 4, CNVL, CNV2, CN6, and the carotid. CN2 and CNV3 do not run through it. The only other anatomy trivia I can think of is that CN6 runs next to the carotid, the rest of the nerves are along the wall. This is why you can get lateral rectus palsy earlier with cavernous sinus pathologies. Coronal. I. Skull fusion, craniosynostosis. The craniosynostosis are discussed in more detail in the congenital section. I'll briefly touch on what is normal. The sutures exist to allow for rapid brain growth over the first few years of life. The brain will double in size within the first 6 months and double again by the second year of life. The majority of skull growth occurs by age 3, at which time most of the sutures will fuse. Some, like the petrooccipital, will remain open into adulthood. When they fuse too early, that causes a problem. The long Latin French sounding word that goes along with that fusion problem makes for a good multiple choice test question. More on this later. IAC, nerve orientation. The thing to remember is 7UP and cope down, with the 7th cranial nerve superior to the 8th cranial nerve, the cochlear nerve component. As you might guess, the superior vestibular branch is superior to the inferior one. If it is shown, it is always shown in this orientation. Orientation. The ideal sequence to find it is a heavily T2 weighted sequence with super thin cuts through the IAC. CN7 superior vestibular. Inferior vestibular. Fundus of the /ACI. 127. Vascular anatomy. Vascular anatomy can be thought 0 facial, 0 occipital, 0 posterior, auricular, 0 maxillary, 0 superficial temporal. Anterior circulation, carotids. Some trivia about the CA, internal carotid. Presence of branches is a way you can tell ICA from ECA on ultrasound. Flow reversal in the carotid bulb is common. Segment by segment trivia, CL, cervical formation. Main pathologies of interest at this level. Atherosclerosis, the origin. Origin is a very common location dissection, can be spontaneous, women, and in Marfan's or Ehlers-Danlos, and result in a partial homers, ptosis and meiosis, followed by MCA territory stroke, can have a retropharyngeal course and get drained by ENT accidentally. Pharyngeal infection may cause pseudoaneurysm at this level. 128. L. C2 Petrus, not much goes on at this level. Sometimes aneurysms, which can be surprisingly big. C3, lacerum, not much here as far as vascular pathology. The anatomic location is important to neurosurgeons for exposing Meckel's cave via a transfacial approach. C4, cavernous aneurysms here are strongly associated with hypertension. This segment is affected by multiple pathologies including the development of cavernous, carotid fistula. C5, clinoid and aneurysm here could compress the optic nerve and cause blindness. C6, ophthalmic, supraclinoid common site for aneurysm formation. Origin at the dural ring is a buzzword for this artery. C7, communicating, terminal and aneurysm here may compress CNM and present with a palsy. PCOM ophthalmic. Ophthalmic. Lateral ICA run. L. C2 petrous, not much goes on at this level. Sometimes aneurysms, which can be surprisingly big. C3, lacerum, not much here as far as vascular pathology. The anatomic location is important to neurosurgeons for exposing Meckel's cave via transfacial approach. C4, cavernous aneurysms here are strongly associated with hypertension. This segment is affected by multiple pathologies including the development of cavernous, carotid fistula. C5, clinoid and aneurysm here could compress the optic nerve and cause blindness. The big ones to remember are in the chart. Venous trivia. Superficial. Superior cerebral vein, superior. Venous trivia. Trivia. Superficial. Regulate temperature and equalize pressure. These are bad because they allow for passage of sinus infection, eye inflammation, which can result in venous sinus thrombosis. Inverse relationship. There is a relationship between the vein of lab and the anastomotic vein of Trillard. Since these dudes share drainage of the same territory, as one gets large the other gets small. Sounds Latin or French. As a general rule, anything that sounds Latin or French has an increased chance of being on the test.